Hello, I'm Ulrika Wolf, a clinical hypnotherapist and strategic psychotherapist. In this briefing, I want to provide a practical and balanced introduction to the evidence for clinical hypnosis. Clinical hypnosis is an interesting area because of its intersection between attention, expectation, imagination, learning, and therapeutic communication. For selected clients and selected clinical purposes, it may help people regulate distress, respond differently to discomfort, rehearse more useful responses, and participate more actively in their own symptom management. It's also an area where the evidence is sometimes overstated, oversimplified, or applied too broadly. So the aim of this briefing is not to answer this question unequivocally, does hypnosis work? With a simple yes or no. A more useful clinical question is, what does the evidence show for this particular application with this particular group of people and for this particular outcome? Keeping in mind as well the limited funding for this type of research. That question allows us to understand both the potential value of clinical hypnosis and the boundaries of what can be reasonably claimed. One of the first things to understand is that clinical hypnosis is not a single, uniform intervention. The term can describe a range of therapeutic approaches used in very different clinical contexts. For example, a person with irritable bowel syndrome may complete a structured gut-directed hypnotherapy program delivered over several sessions. A patient undergoing a medical or dental procedure may receive brief hypnotic intervention designed to reduce distress or support pain management. Another client may experience hypnosis as a part of psychotherapy, where it's used to support mental rehearsal, attentional flexibility, emotional regulation, or a different response to a difficult internal experience. These interventions may all involve hypnosis, but they differ in their clinical purpose, structure, language, number of sessions, delivery method, and intended outcome. They may also differ considerably in the training and experience of the practitioner delivering them. This distinction is important because evidence for one specific hypnosis protocol should not automatically be used to validate every intervention described as hypnotherapy. The strongest clinical conclusions are generally those that remain close to the treatment model, the population, and outcome that was actually studied. Some of the more developed evidence relates to structured, condition-specific applications. Gut-directed hypnotherapy is one of the best-known examples. This is a structured intervention designed specifically for symptoms associated with disorders of gut-brain interaction, including irritable bowel syndrome or IBS. Research suggests that gut-directed hypnotherapy may improve overall IBS symptoms and abdominal pain for some patients. This may be particularly relevant where symptoms continue despite appropriate medical assessment and management. The important point is that these studies generally involve medically assessed patients and defined gut-directed treatment protocols. The evidence does not mean that any hypnosis recording, general relaxation exercise, or unrelated hypnotic intervention will produce the same outcome. It also does not mean that hypnosis treats every biological or medical contributor to IBS. A more accurate interpretation is that gut-directed hypnotherapy may offer an additional symptom management option within appropriate multidisciplinary care. Clinical hypnosis has also been studied in medical, surgical, and dental environments. In selected settings, research suggests that it may help reduce procedural pain, anticipatory anxiety, or distress. This may involve helping the patient direct attention differently, feel more settled before the procedure, engage with discomfort in a less threatening way, or use imagery and suggestion to support coping. In this context, hypnosis is generally used as an adjunct. It does not replace anesthesia, sedation, analgesia, medical monitoring, or the procedural care itself. Its potential value is in helping the patient manage aspects of the experience more effectively. It's also important not to generalize procedural findings too far. Evidence that hypnosis may reduce discomfort during a brief procedure does not necessarily establish that it will improve chronic pain, resolve an underlying medical condition, or change long-term recovery. Again, this specific application matters. The distinction between acute and chronic pain is also particularly important. Hypnotic suggestion has produced meaningful reductions in experimental pain and in some acute clinical settings. This suggests that attention, expectation, interpretation, and suggestion can influence how pain is experienced. However, many experimental studies involve healthy volunteers, brief discomfort, and immediate outcomes. Chronic pain is considerably more complex. It may involve neurological, musculoskeletal, inflammatory, visceral, psychological, and social factors, often interacting over a long period of time. Research into hypnosis for chronic pain is mixed. Some reviews report small to moderate improvements in pain intensity, coping, or pain interference. Other reviews conclude that the average effect is modest, inconsistent, or supported by low certainty evidence. But this does not mean hypnosis has no place in chronic pain care. For selected patients, it may assist with symptom management, distress tolerance, attention, pacing, sleep, or the perceived impact of pain. However, it should generally sit within a broader care plan and should not be presented as a universal treatment, a substitute for a diagnosis, or a replacement for medication, rehabilitation, or specialist pain management. There are other applications where the research is encouraging but still developing. Hypnosis has been studied for menopausal hot flushes and night sweats. Some trials have reported clinically meaningful improvement, including improvements compared with control or sham interventions. And these findings are promising. At the same time, improvements seen in comparison groups suggest that expectancy, treatment credibility, therapeutic attention, and other non-specific effects may also contribute. The most responsible conclusion is therefore that hypnosis may be beneficial for some women, but the evidence should not yet be interpreted as definitive or universally applicable. Sleep is another area of interest. Some studies report improvements in sleep quality, sleep onset, or the experience of nighttime wakefulness. Hypnosis may be useful in helping selected clients reduce arousal, disengage from unhelpful monitoring of sleep, or rehearse a calmer response to wakefulness. However, the research includes small samples, varied protocols, and considerable reliance on subjective outcomes. For chronic insomnia, cognitive behavioral therapy for insomnia remains the established first-line psychological treatment. Hypnosis may have a complementary role in selected cases, but it should not be positioned as an equivalent replacement unless it also comes with a specific strategy like a psychotherapeutic approach. Sleep difficulties may also require medical investigation, particularly where there's concern about sleep apnea, medication effects, substance use, mood disturbance, or other sleep disorders. Some of the most heavily marketed applications of hypnosis have less consistent evidence than the public may assume. Smoking cessation is one such example. Some individuals report that hypnosis has helped them stop smoking, and it may support motivation, rehearsal, urge management, or behavioral change for particular clients. However, systematic reviews have not established that hypnosis is consistently more effective than established behavioral support or unassisted quitting at a population level. A treatment can be helpful for some individuals without the evidence being strong enough to support broad claims of superiority or guaranteed success. And it's important to remember that too as an option. Everyone is different. but evidence related to smoking should not automatically be extended to vaping. While the behaviors may overlap, vaping products, usage patterns, and dependence mechanisms are not identical. Psychological presentations require similar care in interpretation. Positive findings have been reported in individual studies involving depression, anxiety, and related symptoms. However, situational anxiety before a medical procedure is not the same as generalized anxiety disorder, panic disorder, or social anxiety disorder. Likewise, a positive trial involving mild to moderate depression that does not establish, it actually does not establish that hypnotherapy is generally equivalent to established psychological treatments across all levels of severity and clinical complexity. At present, hypnosis is better understood as a possible adjunctive intervention in selected cases rather than as a universal first-line treatment for depressive or anxiety disorders. Trauma-related work requires particular caution and competence as well. Hypnosis can increase engagement with imagery, emotion, and internal experience. For some clients, this may support stabilization, rehearsal, and therapeutic processing. For others, it may intensify distress, increase dissociation, or create confusion around memory. Suggestive methods may also influence confidence in memories, which is one reason that hypnosis should not be used to recover supposedly hidden or repressed memories. A trauma diagnosis does not automatically mean that hypnosis is unsuitable. Suitability depends on the person's current stability, risk, dissociation, treatment goals, support network, and the practitioner's training and competence. Some clients may require stabilization, psychiatric input, or specialist trauma-focused care before experiential work is considered. Established trauma treatments should not be displaced without a clear clinical rationale. Clinical hypnosis research has several recurring methodological challenges. Different studies may use different definitions of hypnosis. The scripts, suggestions, treatment duration, number of sessions, and practitioner backgrounds may vary substantially. The comparison group also matters. A study may compare hypnosis with a waitlist, usual care, education, relaxation, another therapy, or sham hypnosis intervention. These comparisons do not answer the same question. A waitlist does not control for therapeutic attention, expectation, support, or treatment credibility. A sham intervention may still contain active components such as relaxation, imagery, focused attention, and positive expectation. Blinding is also difficult because participants usually know they are receiving an intervention intended to help, and practitioners generally know what they're delivering. Many studies are small, single-center, or limited to short-term follow-up. These limitations do not make the research meaningless. They simply mean that the findings need to be interpreted carefully and in relation to the specific treatment, comparison, and outcome. People also differ in how they respond to hypnotic suggestion. Research suggests that hypnotic suggestibility can influence response, particularly in some experimental pain studies. However, suggestibility is not a universal predictor of clinical success. A person with lower measured suggestibility is not automatically unable to benefit. A higher suggestible person is not guaranteed to improve. Clinical outcomes may also depend on the appropriateness of the treatment target, the quality of the intervention, the therapeutic relationship, expectancy, engagement, between session practice, and the broader clinical context. For this reason, treatment planning should not be reduced to a single suggestibility score. Clinical hypnosis is generally regarded as a low physical risk intervention when it's used appropriately. However, adverse events are not consistently collected or reported in the research. It's therefore more accurate to say that relatively few adverse events are reported than to claim that hypnosis is completely risk-free. Potential concerns may include emotional distress, unwanted imagery, increased symptom focus, destabilization, confusion relating to memory, or delays in accessing more appropriate care. The quality of assessment is therefore essential, so are informed consent, practitioner competence, clear treatment boundaries, and appropriate collaboration with medical, psychiatric, or psychological professionals where required. Clinical hypnosis is not an emergency or crisis service either. A person experiencing an immediate risk of self-harm, harm to another person, acute psychosis, delirium, severe confusion, acute mania, severe intoxication, withdrawal, or another medical or psychiatric emergency requires urgent specialist assessment. In my own work, I do not select hypnosis simply because a person has a particular diagnosis or presentation. I consider what the client wants help with, what process or symptom is being targeted, and whether hypnosis is relevant to that specific goal and would work with that specific client. I also consider whether medical or psychological assessment is required, whether another practitioner should remain involved, and whether the proposed work is within my competence and scope. The client should also have a realistic understanding of the likely benefits, uncertainties, and limitations. I use hypnosis as one possible method within a broader therapeutic strategy. It may be used to support focused attention, mental rehearsal, symptom management skills, emotional regulation, or practice responding differently to a familiar trigger. The hypnosis should serve a clear therapeutic purpose. It should not be used simply because it is available, and it should never be presented as a standardized cure or solution or a substitute for necessary medical, psychiatric, or psychological care. The evidence for clinical hypnosis is not universally strong or universally weak. It is application specific. More developed evidence exists for areas such as gut-directed hypnotherapy, IBS, and selected procedural pain and distress outcomes. Evidence for acute pain is supportive but should not automatically be generalized to chronic pain. Research relating to chronic pain, sleep, menopausal symptoms, and some psychological applications remains mixed and developing. For smoking cessation, broad psychological conditions, trauma-related presentations, weight loss, and general behavior change, the evidence does not currently support sweeping claims. The evidence cannot be applied so broadly. The most useful clinical question still remains: is the available evidence relevant to this client, this application, and this intended outcome? And when used carefully, transparently, and within an appropriate treatment framework, clinical hypnosis may offer a valuable adjunctive method for selected clients and an option. Thank you for taking the time to learn more about the evidence for clinical hypnosis. You can read more about the full briefing on the Online Hypnotherapist Clinical Briefings Hub.
The Clinical Briefings Hub is a free, dedicated professional resource for GPs, specialists, and allied health practitioners who would like more detailed information about clinical hypnotherapy, strategic psychotherapy, and referral considerations. The Clinical Briefings Hub is a separate space that allows you to explore the complete evidence-informed briefings behind the information on the main website. When you open a briefing, you will see the estimated reading time at the top so you can decide whether to read it now or later. Each briefing also includes call-out summaries that highlight important clinical points and practical information for quick review. The content is divided into clear sections, allowing you to move to the information that is most relevant to you. You can also expand or collapse sections as needed and skip to the sections that are of most interest. You can also review the supporting sources in the footnotes and click directly through to available research, professional guidance, and further reading. The complete briefings include all three collections, foundations, clinical, presentations, and the referral process. And you can see there's far more here as well for you to access. Health practitioners can freely access the clinical briefings by subscribing to the Online Hypnotherapist Professional Updates.